Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, blood-brain barrier and its clinical significance. We need to understand blood-brain barrier because there are so many pathological processes which affects blood-brain barrier. So unless we understand the blood-brain barrier, we cannot go forward in understanding the pathogenesis, the management part and the treatment. So here we go, the blood-brain barrier and its clinical significance, which is simplified. Why in the first place we need a blood-brain barrier? 15% of the cardiac output goes to the central nervous system. So 15% of the cardiac output goes to the central nervous system. So there's a lot of blood going to the central nervous system. So along with it, some toxic substances in the blood may also enter the brain and can seriously impair the functions of the brain. So in order to protect the brain from these toxic substances which may be present in the blood, the nature has designed the blood-brain barrier. So when there is a blood-brain barrier, not all substances in the blood can enter into the brain. So it puts a barrier, it puts a check onto the substances which can enter from the blood to the brain. So this is known as a blood-brain barrier, the barrier between the blood and brain. Now let's see what are the constituents of this blood-brain barrier. Basically we have three components which take part in the blood-brain barrier. One is these endothelial cells which is on the side of blood. As I said, this is the barrier which is between the blood on one side and brain on the other side. So the components are one, the endothelial, the tight endothelial cells, the tight endothelial junctions of the endothelial cells of the capillaries, which forms the first component. The second is you have the astrocytes, you have the astrocyte foot processes. So these are the second component. And the third component is that we have a basement membrane in between the endothelial cells and astrocyte foot process, where there are pericytes also. So the endothelial cells on the blood side, the astrocyte foot process on the brain side, and in between the basement membrane with pericytes, these together form the blood-brain barrier. So it's a barrier between the blood and the brain which will not allow many substances of the blood to enter into the brain. It's a selective semi-permeable membrane. So what is the pathogenic mechanisms, or what are the reasons which make this semi-permeable membrane highly selective for some substances, and some substances it is impermeable? There are basically three reasons for the effectiveness of this blood-brain barrier as compared to the other areas. The other areas do not have this barrier, so that anything we inject into the blood will come out, will get into the organs. So actually first it was discovered that the blood-brain barrier was there by injecting a dye into the body, and they found that the dye was present everywhere except the central nervous system. So that's how they realized that there's a barrier between the blood and the brain. So there are three reasons which give effectiveness to this blood-brain barrier. First is these tight junctions. You can see these endothelial cells on the capillary wall. They are very close together. They are very close together. In fact, there are some substances called occludins, which whatever little space is there, it will try to fill up that little space also between these endothelial cells. So there are tight junctions of the endothelial cells. So anything in the blood cannot enter easily into the brain. So tight endothelial cells, the tight junctions of the endothelial cells which are occluded by occludins. So the tight junctions, this is the first step in the blood-brain barrier. So this is known as the paracellular route. So anything in the blood generally goes in between the endothelial cells, but since there are tight junctions, it will not allow substances in the blood to enter into the brain. So the paracellular route. So the large molecules, the charged molecule or water soluble molecules are denied entry into the brain. So this is the paracellular route. Para means parallel. So between the cells, the substances in the blood are not allowed to enter into the brain. The second is the transcellular route. That is onto the cell going into the brain. So through the cell going into the brain, through the endothelial cell going to the brain. This is known as transcellular route. Here we have special vesicular transport systems which will transport these substances through the cell. This is also highly effective and it will not allow substances to enter into the brain. The third is that we have a P glycoprotien active transporters. So lipid soluble neurotoxic drugs may try to enter into the brain because they are lipid soluble, but then again this blood-brain barrier will not allow these substances to enter into the brain by acting to the P glycoprotein. So the effectiveness of the blood-brain barrier is basically because of three reasons. One is the tight endothelial junctions because of occludins and the paracellular route being closed. Second is the transcellular route going through the endothelial cells are closed. The fenestrated capillaries there are no fenestrated capillaries, it is shut down. And third, the P glycoprotein active transporter system, it acts on it and will not allow the substances in the blood to enter the brain. So these three are the main reasons for the effectiveness of the blood-brain barrier. Right. Now, let's see what are the substances which can cross the blood-brain barrier. What are the substances which cannot cross the blood-brain barrier? The substances which cannot cross the blood-brain barrier is one, the large molecules. Example, plasma proteins. The large molecules, plasma proteins cannot enter the blood-brain barrier, or anything which has to join the plasma proteins, covalently join the plasma proteins and enter, they are denied entry. Second, the charged particles, the highly polar water soluble substances, they also cannot cross the blood-brain barrier. And the toxins, the neurotoxins especially, cannot cross the blood-brain barrier because of the effectiveness of the blood-brain barrier. So now comes another question, what are the substances that can cross the blood-brain barrier? Small molecules can cross the blood-brain barrier like oxygen, carbon dioxide, and lipid soluble substances like volatile anesthetics, alcohol. These are, since lipid soluble, they can cross the blood-brain barrier. Remember, water soluble molecules cannot cross the blood-brain barrier, whereas lipid soluble substances can cross the blood-brain barrier. The large molecules like plasma proteins cannot cross. The small molecules like carbon dioxide, oxygen can cross. Right. Now I'm going to talk about a very important point in terms of glucose. Brain depends so much on oxygen and glucose for its survival, and therefore whatever may be the tight barrier of the blood-brain barrier, whatever may be the effectiveness of the barrier, brain somehow wants to take in glucose for its survival. So nature has designed special ways of the brain trying to acquire glucose, even though the blood-brain barrier is effective. This is possible through the special transport system, the special transporters, glucose transporter 1. So glucose transporter 1 is the special transporter system which takes glucose from the blood into the brain. This is a very important concept. I'll be talking more and during the clinical significance of this blood-brain barrier. But here I just want to mention that in meningitis, be it pyogenic meningitis or tuberculous meningitis, the glucose goes down in the CSF. It is not because of the bacterial multiplication the glucose goes down. It is because these microorganisms inhibit this special transporter system, the glucose transporter 1. Because of this inhibition of the glucose transporter 1, the glucose level in the CSF goes down. So in meningitis, we get a decreased CSF glucose because the glucose transporter 1 system is affected, and therefore glucose cannot be transferred from the glucose into the brain, from the blood into the brain. So we have a decreased glucose level in the CSF. This glucose transporter 1, substance 1, is independent of insulin. So whatever may be the level of insulin, this transporter system will be effectively acting and therefore trying to transfer glucose from blood into the brain. So this is a highly protective and well designed mechanism by the nature, because brain depends on so much of glucose and oxygen. So brain needs glucose at any cost, and therefore a special system has been designed for entry of glucose from blood into the brain through the glucose transporter system 1, which is independent of insulin levels. Right. Another important transport system is for amino acid. Again, here there's an important clinical concept. We all know that in Parkinsons, the dopamine is deficient, but we can't give dopamine because it cannot cross the blood-brain barrier. So we give a precursor of dopamine, that is levodopa. Levodopa, again using a special transporter system, can cross the blood-brain barrier. So though these are protein bound, they have special transport systems by which glucose and the amino acids like levodopa, it's a precursor of dopamine, can break the blood-brain barrier, cross the blood-brain barrier and enter the brain. And steroids also, which are not protein bound, can enter the brain. So to summarize, the small molecules, the lipid soluble molecules can cross the blood-brain barrier and enter the brain. The glucose, with a special transport system, glucose transporter 1, which is independent of insulin levels, can transport glucose from the blood into the brain. Likewise, though dopamine cannot enter the brain because of the blood-brain barrier, the precursor of dopamine, namely levodopa, can enter the brain by crossing the blood-brain barrier, and steroids, which are not protein bound, can enter the brain. Talking about steroids, again this is a very important concept. When there is inflammation of the meninges, when there is infection of the brain, of the steroids, we give only dexamethasone. In fact, one of the residents was asking me why we give only dexamethasone as steroid, why not other steroids? The answer being, already there is edema. We have vasogenic edema. There's a lot of fluid, there's a lot of sodium. And on top of it, if we give a steroid which has got mineralocorticoid activity and retains the sodium and water, it is going to worsen the neurological process further. So when we give steroids to combat inflammation in the brain, we give a steroid which has got the least mineralocorticoid activity, that is dexamethasone. That's why in books or wherever you see doctors giving only dexamethasone in infections of the brain or the inflammation of the brain, and not other steroids. Right. So these are all the important structures, anatomic and physiological correlates we need to understand. Now let's talk about the clinical significance of this blood-brain barrier. There are so many important points which we need to know of the blood-brain barrier, the significance of the blood-brain barrier. So what are the important points? What are the significant points of the blood-brain barrier? First, I said there is a blood-brain barrier so that substances in the blood cannot enter into the brain. But again, nature has given few areas of the brain where there is no blood-brain barrier. We call that as circumventricular organs. Example is area postrema. Here we have fenestrated capillaries so that substance in the blood can enter into the brain easily. This is important because some substances are needed for effective functioning of the brain, so they cannot be filtered off. So we need a break in the blood-brain barrier so that these substances can enter the brain from the blood. So we call that as circumventricular organs. Classic example is there are so many parts where you have a break of the blood-brain barrier. We call that as circumventricular organs. But an example of it is the posterior area postrema. In the fourth ventricle, we also call it as chemoreceptor trigger zone. Again, there's a very important clinical point here. So I'm talking about only the clinical and important points. We give a lot of drugs, including antibiotics, anti-tumor drugs. Most of the drugs, especially the anti-tumor drugs, they cause nausea and vomiting. In fact, in the exams, most of the students, if they do not know anything, also they'll write the side effects of drugs are nausea and vomiting. Why nausea and vomiting is so common when we take drugs? It is because of this chemoreceptor trigger zone where the blood-brain barrier is broken down, the area postrema in the fourth ventricle. Since there is no blood-brain barrier in this area, anything in the blood will enter into the brain directly, and therefore drugs will enter this chemoreceptor trigger zone because there is no blood-brain barrier there and stimulate the chemoreceptor trigger zone. Therefore persons will start having nausea and vomiting. So one of the common side effects which we see when we take drugs is nausea and vomiting, and the reason behind the development of nausea due to drugs is because of the stimulation of chemoreceptor trigger zone because of absence of blood-brain barrier, right? And other causes which can break the blood-brain barrier are trauma and then infections and inflammations. Example, especially in India, tuberculoma, neurocysticercosis. These infections breaks the blood-brain barrier. Again, there's one important clinical point here. We can exploit this situation, we can take advantage of this situation because when we give drugs, many drugs do not enter the blood-brain barrier. But when there is infection like tuberculosis or neurocysticercosis, which breaks the blood-brain barrier, so when we give antibiotics or anti-tuberculous drugs, it enters the brain easily because there's already a breakdown of the blood-brain barrier because of these infections. So in fact, antibiotics and anti-tuberculous drugs penetrate and enter the brain easily because of the breakdown of the blood-brain barrier due to these infections. Hypertensive encephalopathy. Again, when there is hypertension, there is a breakdown of the blood-brain barrier, the edema into the brain. It does not stick to one particular territory, unlike infarction or hemorrhage. It's a diffuse involvement, and therefore person loses consciousness. When you record there's a high blood pressure, and we have to give anti-edema measures and anti-hypertensive treatment. Tumors. As I said, infections like tuberculosis, neurocysticercosis, they break the blood-brain barrier. Likewise, tumors also break down the blood-brain barrier. An important point regarding the tumors and the blood-brain barrier is that the tumors break down the blood-brain barrier, the tight junctions, and there are new vessel formation when there is tumor, but this time when these vessels are formed, there are no tight junctions. So when there is a tumor, it destroys the tissue and new vessels are formed, but in these vessels which are formed, there are no tight junctions, and therefore anything in the blood can easily enter the brain. And therefore in infections and tumor, there's a breakdown of the blood-brain barrier, and anything we give like drugs, antibiotics enters the brain easily. Radiations also breaks down the blood-brain barrier. Yeah, HACE, high altitude cerebral edema. High altitude, when we go and start climbing mountains or go on a higher altitude, what happens? We develop hypoxemia. The mitochondria is present in the cells which are so much dependent on oxygen. So when we climb hills or go to a high altitude, the mitochondria are affected, and again there's a breakdown of the blood-brain barrier. So when there's a breakdown of the blood-brain barrier, again the edema follows, the fluid follows, enters into the brain and causes vasogenic edema. So when there is high altitude cerebral edema, there is vasogenic edema because the mitochondria are affected, the blood-brain barrier is broken down, and solutes and fluids enter the brain easily. So again here we give dexamethasone, the steroid. Why we give only dexamethasone? Because dexamethasone has got the least mineralocorticoid activity. So when we are treating cerebral edema, we should reduce it. We should reduce the inflammation, we should reduce the edema. But when you give other steroids, it may reduce inflammation, but there is mineralocorticoid activity and edema may be produced. So in conditions where there is hypotension like sepsis, there we give drugs, steroids which has got mineralocorticoid activity like hydrocortisone in sepsis, where there is hypotension where you need to increase the blood pressure. But in these conditions where there is already edema, you give steroids which does not further enhance edema. That implies that they should have the least mineralocorticoid activity. Right. Another important clinical point regarding the blood-brain barrier is a pediatric condition, the kernicterus. We all know that babies, the liver enzymes are not well formed, so unconjugated bilirubin may be increased, glucuronide transferase enzymes may not be well formed, there's a prematurity, and therefore this unconjugated bilirubin may go and affect the basal ganglia and can produce the neurological disorder, the kernicterus. As I said earlier, another important clinical point of the blood-brain barrier is levodopa. In Parkinson's disease, though there is a deficiency of dopamine, we don't give dopamine and we can't give dopamine because dopamine does not cross the blood-brain barrier. So what we do is that we trick the brain by giving levodopa, a precursor of dopamine, which enters the blood-brain barrier, and then in the brain it gets converted into dopamine. So we have developed a trick so as to treat Parkinson's patients despite intact blood-brain barrier by giving a precursor of dopamine, namely levodopa. Right. As I said, as I mentioned, in meningitis, again there is a breakdown of the blood-brain barrier, and then the glucose level in the CSF is decreased. The glucose level in the CSF is decreased not because of the increased metabolic activity and it is taking glucose for its survival, because the CSF glucose is reduced even after the clearance of the pyogenic bacteria. So it is said that the microorganisms impair the transport of glucose transporter 1, which is insulin independent, and therefore glucose cannot be transferred from the blood into the brain, and therefore glucose decreases in infections like pyogenic meningitis or tuberculous meningitis. Right. In meningitis, as I said, we give steroids, only dexamethasone, because it has got no mineralocorticoid activity. Alcohol, if we take alcohol here, is a highly lipid soluble substance, and therefore, as I said in the beginning of my lecture, lipid soluble substances can easily enter the brain, and alcohol, since it is lipid soluble, it enters the brain easily despite an effective blood brain barrier, and therefore alcohol can severely affect brain, and that's why we see a lot of CNS toxicity because of alcohol. Because alcohol is lipid soluble, it can enter the brain easily. Likewise, anesthetics, volatile anesthetics, they are also lipid soluble, and therefore when we ask the persons to inhale, it enters the brain easily, and therefore person slips into a sedated state. Right. I told about hypertensive encephalopathy. There's a similar disease like hypertensive encephalopathy, which we call it as PRES, posterior reversible encephalopathy syndrome. This is because of increased blood pressure. We see it in posterior parts usually, but not necessarily, that is the occipital. It reversible, that means when we control the blood pressure, it reverses back. Encephalopathy, the brain gets affected. So we call that as PRES, posterior reversible encephalopathy syndrome. It is usually because of increased blood pressure, but more important than the increased blood pressure is the sudden surge of the blood pressure. The sudden surge, the sudden change of the blood pressure breaks down the blood-brain barrier, more so in the posterior regions, especially in the occipital lobes, because they are more sensitive to the auto-regulation of the brain, and therefore the blood-brain barrier is broken down, and when the blood-brain barrier is broken down, the sodium and the water enters into the brain, causes edema. So you see edema when there is hypertension. You have vasogenic edema because of the breakdown of the blood-brain barrier, and the fluid and sodium slips off from the vessel, enters into the brain, especially in the occipital lobes, because the posterior parts of the brain are more sensitive to autoregulatory changes. They cannot handle hypertension as the frontal regions of the brain can handle. So the frontal regions or the anterior regions of the brain can handle the hypertension better than the posterior or the occipital regions of the brain. So the auto-regulation is impaired. There's a breakdown of the blood-brain barrier, and the sodium and fluid comes out from the blood into the brain. So you see mainly in the occipital regions. So when the occipital regions get affected, you usually have visual impairment. So it is reversible. So the moment you give antihypertensive drugs, it is usually reversible. So PRES is one of the clinically significant point in terms of blood-brain barrier. And finally, imaging. How do we diagnose the breakdown of the blood-brain barrier? As long as the blood-brain barrier is intact, as I said, substances cannot enter the brain. Many substances cannot enter the brain. So how do we diagnose? We can diagnose it imaging wise. When you image a person, you will not be able to visualize some structures well. But when there is infection or inflammation like tuberculosis or neurocysticercosis, the blood-brain barrier gets broken down. So normally substances which cannot enter the brain like dye can enter the brain. And therefore in persons whom you are suspecting to be suffering from infections or inflammation like tuberculosis, tuberculoma or neurocysticercosis, you take MRI, and after that you give a contrast and then see whether the contrast is able to enter the brain because of the breakdown of the blood-brain barrier. And if you see nice contrast enhancing lesions, that indirectly implies that the blood-brain barrier is broken down. So contrast enhancing lesions is suggestive of a breakdown of the blood-brain barrier. Usually in the clinical scenario, if there's fever or associated signs of toxicity, we think of infections like, especially in countries like India, we think of tuberculosis or neurocysticercosis. So again, we take advantage of the situation where the infections break the blood-brain barrier. So drugs can enter easily, the contrast can enter easily, and the lesions appears contrast enhancing. So the blood-brain barrier topic is very important to understand so many clinically significant points, and therefore a knowledge of blood-brain barrier is essential when we start dealing with the neurological disorders. I really enjoyed giving the lecture, and I hope you also enjoyed listening to this lecture. If you have any comments, queries, kindly post it on my YouTube channel. Please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.